Well, thanks for having me, everyone. Truly a pleasure to be here, and especially in our hometown. Only had to drive a few minutes to get here, which is always the best part, right? So looking forward to many discussions that follow from this. Patient experiences. What an amazing topic for us to discuss, particularly around health IT, digital health, precision medicine, and much of the things that I'm sure everybody in the room is working on. Do it from here. So as much as we would like to think that the digital engagement of healthcare, looks like this, your smartphone is an incredibly pleasurable device to use. In healthcare, it's kind of more like this. And I probably all agree with it. These are my disclosures. So we'll start with just a very basic question, right? Do you use a digital health device as part of your healthcare? Show of hands. Yeah, see, I'm asking in Southern California. Right? So second question, have you prescribed a digital health device to your patients, for those who are practitioners, or been prescribed a device by your physician? Show of hands. See, much fewer, 5 hands. Right? So I asked this question for the first time at the Computer Science Museum on Google's campus last year. Everybody's hand went up in the air. Asked it in Kentucky. The people were like, what's digital health? Right? So coming back to Southern California, it'd be great to have this type of conference, where the meat of the United States is and where patients are actually being seen. So we all know this, a great idea is worth nothing, right? It's 1% idea and 99% execution. As over the past few weeks, I've sort of been thinking about, well, what are we talking about with innovation? And if we think about innovation as idea times implementation, right? And then, I did mathematics as boring in an undergrad, but impact is innovation times scale, right? So if we're looking at patient experiences, it is a one-to-one association, but the question really we have to ask ourselves 2020 is how are we going to bring this to the masses? So using this as a framework and using real-world patient experience and some data that we have, we'll see if this calculus remains true. So what's the scope of the problem? We live in a digital world, but healthcare is largely analog. One of these pictures is the DMV in Los Angeles. The other one is an emergency room in Los Angeles. And I bet we'll have a hard time telling the difference of which one is which, right? And so our patients, our users, our consumers, they still live in a very analog world, particularly when they come to access healthcare. Ask a basic question. What are your organization's top 3 priorities for improving the patient experience? It's not a new term. It's catched for the past few years, but been around for decades. And there's certainly more than 3 terms, right? You ask patients those same questions, you'll get largely similar responses, right? But what ultimately turns out to be important? We look from the provider's end, right? And it's equally complex, right? So there are national census data in the United States over the past 10 years that are monitoring healthcare quality and outcomes. And if we look at it over the last decade, we haven't seen any change in treatments. There's been no change in recommendation of preventative treatments. There's been no uptick in cancer. There has been in cancer screening, but no significant difference over the past 10 years. If we look at inappropriate testing, which is one of the quality metrics in the United States, particularly from CMS, we haven't seen a drop in inappropriate testing. We're still consuming healthcare resources probably at a near peak of what we've seen over the past 2 years. Well, now enter the electronic medical record and health IT, right? Of course, we love the digitization of records and the ability to monitor data. But when we look at the usability, and many people might agree, it makes for an interesting debate as well, is what are physicians viewing as their utilization metrics, and are they using it efficiently? In a very interesting time motion study done across 4 specialties, they found that physicians on electronic medical records, for every 1 hour of patient care time, there was an additional 2 hours of time dedicated towards documentation. I won't make the argument that one leads to the other, right? But there's certainly a factor as far as efficiency and how we're not improving healthcare quality. So we need a paradigm shift. We have to move from reactive to preventive, from medicine and promote wellness, hospital to home, and wealthy to the masses, right? We're also in a generational change, right? Our millennials are growing up, right? These are digital, they're born with digital. We merely adopted it. So what are the solutions, or what are potential solutions, right? Enter digital health, right? And Dr. Topol has famously said that digital health is not just about devices, right? It is really the whole spectrum of innovations to help address personalized and individual health. This is from exposome sequencing, microbiome in your gut, metabolome, transcriptomes, imaging, biosensors, social media, social graphs, and now all the way out to consumerization of healthcare. So we're seeing a change. And if we were to categorize digital health, it's not just devices, right? It's far more than that. Looking a little bit closer to see, well, the rate of change of the digitization of healthcare can be seen through technologies. This is an ECG, right? Largely has not been iterated or innovated upon since it was invented in the 1880s, right? And if you take apart one, there's about 300 different pieces in them, right? But that 300 pieces has now been miniaturized to one part, right? Your smartphone EKG, single lead, point of care, consumer device. Well, that one part can do 6 leads on an ECG. For those of you who've had an ECG, that's quite a remarkable feat. Well, that one part can now be done on your watch, right, to measure your ECG, right? Getting more and more towards the user, more and more towards their experience. And finally, I hope this plays, this has been miniaturized.
In this example, the pulse signal is amplified 100 times.
Just by merely looking at a camera. Camera technology is so sensitive that we can detect blush changes of capillary flow at the level of your fingers and level of your face. Measure heart rate and heart rhythm with 0 parts. And as that's grown, there is a whole suite of smart devices. Smart rings for sleep monitoring, smartphone eye exams for global health applications for retinal diseases, smart necklaces for heart failure tracking, computers on your skin, smart pills with nanosensors embedded into medications to monitor medication adherence monitoring, smartphone laboratory testing, even smartphone genome sequencing. The original genome sequence, to sequence the human genome was a device, multiple devices that probably filled this room. It's now on a USB stick that can be attached to your smartphone. Smart clothing, smart watches. Right? So thinking about the patient experience and their engagement, these are wearable wireless technologies that hopefully change that. But, outside of our walls in healthcare, there have been large moves and changes. CVS-Aetna merger. We don't know what that means as yet. Perhaps some in the room do. But here we see a supply chain vendor with a healthcare insurance company outside of a healthcare institution with no doctors. Right? This is clearly a change. What does it mean for experience, quality, cost, outcomes? Right? Google's Alphabet had acquired DeepMind, which is a artificial intelligence organization out of the United Kingdom, and they got access to the entire UK's healthcare system's data, aggregated healthcare system that shared it with Google, right? To say, well, now tell us about the future of healthcare through our data. Certainly wasn't given to us, but given externally. Finally, Amazon, JP Morgan, that made very large investment into their $60 billion healthcare startup, where some are predicting that Amazon Prime is going to have doctors that will be sent out to you. It may not come to that, but we are going to see changes in the consumerization of healthcare. Well, it goes even deeper than that. Look at funding over the past few years. This isn't over decades, this is just over the past few years. Right? Digital health funding from Silicon Valley. This hasn't been updated, but last year probably saw over $20 billion in funding. So there's a lot happening outside of our walls. Now, most of you might be familiar with Apple's announcement for the ECG on the watch. Right? So wonderful announcement. It's an FDA-approved device before any data had been published on its effectiveness and its efficacy. So we have a new device. So questions come up. You can create a new digital health device and then find the healthcare problem. Sounds very Silicon Valley. Versus identify the healthcare problem and then integrate a new device. It's probably what many in the room see as how they solve a healthcare problem. But clearly there are two approaches now. These may not be at odds, right? How do we bring this together? So clearly there are questions, right? Are these questions, or do we already have the answers? Lots of hype, lots of promises, but there's a lack of evidence in digital technologies and healthcare. Let's take a closer look at these. We often say that young, healthy people, or the worried well, will be your prime engagers for healthcare, for health engagement with, for instance, an activity monitor, right? Like a Fitbit. So in a trial of people between the ages of 18 and 35 who are overweight, said, let's give half of them an activity monitor, and let's not give the other half, an activity monitor, just regular health promotion information. And let's see what happens to activity and weight changes, over time. In contrary to what one would think, there's a paradox. The group that didn't have the activity monitor lost more weight than the group with the activity monitor. Okay. So here at Scripps, a number of years ago, colleagues had undertaken an investigation that looked at chronic disease management. These were people with diabetes and hypertension who were high healthcare utilizers. We often say this, our high healthcare utilizers are going to be the prime operators, consumers, and beneficiaries of digital health technologies. These were people who access the healthcare system more than 4 times in 1 year. Give them a suite of devices, smartphone connected glucose monitor, a LiveCore device, a smartphone ECG, blood pressure, activity monitoring. And the other group, don't give anything. And let's look at healthcare utilization and costs over 6 months. And you know what? There was no change in 6 months. In fact, some might argue that because you gave devices, connected them with cellular platforms, paid for the phones, you may have actually increased their costs. Okay? Well, what about heart failure? No shortage of interest in improving the quality metrics for heart failure. In the largest randomized trial that gave heart failure patients who had a hospitalization devices at home to monitor blood pressure, weight, heart rate, and oxygen, compared to those that didn't, there was no change in heart failure readmissions at 1 month or 6 months. Okay. Well, coming back to the United Kingdom, there's a lot of good information that has come out over the past 7 years. And the largest telehealth trial of 3,000 elderly patients with diabetes, COPD, or heart failure were given their smart homes, devices, carbon monoxide detectors, fall detectors, and said what would happen to healthcare utilization in an aggregated healthcare system over 6 months. What they showed was no change, but an increased cost among people who were monitoring their health. And so there's a paradox. These are the groups of people that we're looking, for the future in the digitization of healthcare to improve healthcare quality, but we're finding results that are the opposite. So what evidence we do have is largely negative. So digital health is supposed to improve outcomes, it's supposed to reduce costs, and it's supposed to promote health and wellness. So why does it not? Well, these are not our patients, right? Our patients are more like this, right? And actually, old elderly people will teach us a lot about what they can and cannot do with devices, right? So, it's not just about devices, right? It's a shared system. It's about digital doctors and it's about digital patients. And there are so many different metrics that go into this that many of you will already be familiar with. The devices are clear, we've discussed those. From the physician's end and the care provider's end, the nursing end, right? It's workflows, it's EMR integration, it's precision health. It's what is meaningful data? How do you separate signal from noise, right? What population medicine, population health will change a lot, right? In looking at this shared ecosystem. But from the patient's end, engagement is very important. What is patient-generated health data? Are patients digitally literate? Got my mom a cell phone 2 years ago. She's still pretty digitally illiterate, right? What does digital engagement look for patients and their caregivers? What is retention? Patient-reported outcomes. There's more questions than we have answers. So as we move from technology to data to knowledge, and we use our motivating example of the digital patient engagement, we'll show some examples on our real-world digital health programs here at Scripps and also outside, along how we move this needle in order to better engage and better activate our patients. We're familiar that in high-tech care and web-supported care, that people monitoring health data from home, right? It's consumerization, remote patient monitoring. Well, we have to ensure that individuals are monitoring their data. We also have to have a system in order for that data to be populated either in the cloud, but have access to physicians and healthcare providers for decisions. So bridges have to be created. Right? Well, what do those bridges look like? Are they direct EMR integration? Is it automated clinical decision support? Right? Is it a third-party application that healthcare institutions and clinics partner with in order to monitor data from home? But it has to be an iterative and cyclical process where the data is reviewed and also back to patients and caregivers for healthcare decisions. And once this loop is completed, we can now look more granular at patient engagement. We can look at real-time patient outcomes and patient-reported outcomes. Largely, in our experience, there's probably just a handful of devices, right? A handful of technologies that complete this loop, right? That are able to monitor people at home, have data available to physicians, and then come back to patients and caregivers. And so there's a lot of work that needs to be done. Okay, the heart failure epidemic in the United States last year saw a peak. It'd be great to take this call. In heart failure hospitalizations in the United States, and it's eclipsed over 1 million. This doesn't include readmissions. These are these are just hospitalizations. And if we look at the prevalence of the disease, which has also eclipsed over 5 million people in the United States, underestimated because the manner in which we are diagnosing doesn't catch everybody out who has not had a healthcare encounter. We see about 1 million new cases a year, and in elderly patients, greater than 50% of them will have heart failure. Now, this costs the healthcare system a significant amount, at minimum $40 billion. But there's also a lot of indirect costs, and that's loss of productivity from patients, from their caregivers, right? This has financial implications, right, for the very people that we're trying to improve their outcomes. When taking a closer look at digital monitoring and remote patient monitoring for heart failure, right, as we were saying before, right, we did not see a change in heart failure readmissions at 1 month or 6 months or mortality in individuals who were monitored at home. Well, our colleagues in Canada said it's not just a technology-based problem, right? This is about mobilizing healthcare practitioners, right, versus no touch. So they embarked on a similar investigation and said, here in Toronto, where I'm from, right, let's identify individuals who've had a heart failure hospitalization. And prior to them leaving the hospital, we will send nurses to their home 2 to 3 times per week in order to ensure medication compliance monitoring, in order to ensure their vital signs, in order to ensure that they're feeling okay. And also as a method to provide feedback back to their healthcare providers. And compared to people who didn't have high touch, there was no change in readmissions of 20% at 1 month. On one hand, technology didn't change what we're looking at as the quality metric for heart failure readmissions. Well, on the other hand, high touch, right, didn't seem to change healthcare utilization, right, in a similar population. So again, back to our paradox. So in heart failure, is telemedicine ineffective, or is it just ill-used? We're not using it in the right people. Right? So my daughter just turned 2 a couple of weeks ago, and so I've taken an interest in how she learns. Right? And if you look at how kids learn, they really ask the hard and basic questions. Where are the learners and where do they need to be? Right? How do you fill this gap? Right? And what you realize is the solution can be very simple, right? It's an individualized approach, right? It's not a one-size-fits-all, right? So if we use a similar theory, right, and apply that to this problem of heart failure, right? What can we infer from new technologies? There's a sensor that we at Scripps, we have the largest clinic in the United States, where we implant a sensor into the pulmonary artery. What does that mean? Like your car, right? In order to monitor the pressure in the car, you put it in a pressure gauge, right? And you know what the pressure is. Right? We can do that in the human body now. And these are people who are walking with a pressure gauge. Right? So almost like a check engine light, right? For individuals who have heart failure. Right? And this is what the procedure looks like. We play music in our cath lab. Right? And for those that see it, it's this gray device over here. It's about half the size of your finger. Completely wireless, battery-free, and so far has lasted in individuals for over 8 years. Take an example, one of our real-world examples. An 88-year-old with 4 hospitalizations for heart failure at our institution. Care navigators, right? Let's get this person the care and the access that they need in order to avert readmissions, also to improve her quality of life, right? And after implantation, which is here, this is the pressure signal, right? What a mechanic would look at in your car over time. Except this data is being monitored real time by nurses in clinic. Right? It expands the skill sets of nurses. Now replaces telephone calls with actually monitoring data. And this data can lead to medication changes. So if medications are changed and pressure is monitored, the pressure comes down. In heart failure, pressure comes down, people feel better. And if they feel better, they're likely not to come back to the hospital, right, for reasons related to pressure being elevated. And after 200 patients here at Scripps, we're really seeing what that transformation means for patients. Right? And when you can improve quality of life in any individual with a chronic disease, now you have a success. Although we're looking at outcomes, readmissions, costs, healthcare utilization, we shouldn't forget about the most important thing, and that is quality of life from our patients. In the main trial, so many people criticize trials for saying you can't replicate a trial in a real world because real world patients are not trial patients. Right? There's so much more heterogeneity, and we just can't monitor the way that you did in a trial. Right? Well, in the main trial, there was a 40% reduction in heart failure readmissions at 6 months because people got their medications increased. Right? Well, that was in 500 individuals in a trial. In the real world example, in 2,000 individuals, we found a similar but greater pressure reduction. People lost a lot more volume, and there was just as much, there was a 60% reduction in heart failure readmissions at 6 months. Right? So we're seeing now that old theory and sort of that dogma that trial patients are not real patients. Well, we're beginning to see that if you can change the manner in which we deliver healthcare, shift the focus, right? Change the teams, we might be able to do even better. In even a larger epidemic example of hypertension, gone are the days of blood pressure cuffs. Right? We now have blood pressure watches that can do beat-to-beat blood pressure. Now, hypertensive patients can't monitor their blood pressure at home, right? At night, right? Because they're sleeping. This is an example of an individual with high blood pressure, but is a nocturnal dipper. That means their blood pressure dropped at night. We've never known these people because we couldn't monitor the data at night. This is important because this individual is at the highest risk of a stroke, but we didn't know who this patient was. Right? So the individualized approach to their treatment, because the data is now available. We can provide better care, we can increase this person's access, and hopefully improve this person's outcome. This is the design of a N-of-1 clinical trial that I'll show you. These are piezoelectric crystals that are put on a bandage, right, on top of the radial artery to monitor passive blood pressure over time. Still early stage, but we might see these over the next few years. Right? By monitoring data more frequently, make that data meaningful data more frequently, we can make similar changes. Get people to target, get blood pressure down. Quality metric for healthcare institutions It means something for patients. Right? So this isn't a research design. How does it look in the real world? Well, we've designed remote patient monitoring blood pressure programs. Say people monitor your blood pressure over time and have that data directly inputted into the electronic medical record for your physician and your primary care provider to create a clinical decision support tool for you that makes your blood pressure improve over time. In this example, this person is enrolled in an average nursing blood pressure program, right? Which is telephone calls on a monthly basis, not monitoring data. The blood pressure is still uncontrolled. Enroll this person in remote patient monitoring. Have them monitor their data, but they know that you are checking and acting upon it. Well, in a matter of a few weeks, by providing data and making it actionable, you can improve blood pressure in a very short period of time. You can also monitor when something changes on the patient's end, such as I forgot my medications. Believe it or not, that's not a very common reason for why people forget their medications. It's usually because of something underlying: daytime sleepiness, fatigue, those patient-reported outcomes that are very important. But by monitoring data, we can catch it before it goes even higher. And in a matter of 3 months, in this 72-year-old, this person's blood pressure is at goal. Right? Change the patient engagement, change the practice. Well, how can we change this even further? Right? For those of you who have access to healthcare systems, right, and have interacted with your physicians, what does an average healthcare encounter look like? You meet your physician, you schedule tests, you wait for those results, and you go back to see the physician. Hopefully something to act upon. How long can this usually take? Any guesses? That's pretty good, right? And go back to Kentucky, it might be even longer, right? But time, right? Well, this is the average among the hundreds of millions of healthcare visitations in the United States. This is what it looks like. Well, why don't we change the experience? Right? Why don't we completely shift? Instead of doing tests later, why don't we do tests up front and then see the physician? So what does a 180-degree shift look like? We started asking these questions because rather than doing the same thing over and over again, right, we took on a social experiment. Say, what if we did the opposite, right? And so change the engagement. In partnership with the American Society of Echocardiography and West Virginia University, we created a program last year called Choice, right? For those of you who are not familiar with West Virginia, it has the highest prevalence of cardiovascular disease in the nation, greater than that of India, right? And it is largely resource limited, right? The people of West Virginia seek access it takes about 200 miles for a patient to get to a clinic, right? So we took this as an opportunity to say, how can we shift the experience? And so in West Virginia, we created 20 digital smartphone health clinics and planted them across the state, right? Partnered with the university, partnered with clinics, and enrolled 400 patients in about 10 hours in October of last year. What do these smartphone clinics look like, right? What were people actually doing? And there was a suite of mobile devices. These are point-of-care devices. So a patient would get an EKG. They would get an ultrasound that we can do on a smartphone in order to look at heart function. There are medical tricorders, right, that can do your beat-to-beat heart rate, your blood pressure, weight, and glucose. In addition to enrolling patients onto a care navigation platform on an app that helped them put together their medications, helped them put together the results of this visitation. Now, these devices were performed by nurses in clinic. At the time a patient entered the clinic, before they saw the physician, they had 15 minutes, about 20 minutes, to get these technologies used and get the data. What was your heart rate? What was your rhythm? What does your heart look like? Your blood pressure, your glucose, your weight, right? And also point-of-care genomics, right? If somebody looked like they may have a genetic predisposition for a disease, we said, sure, let's see what that looks like. And now, present that information to the physician, right, who has that available at the time of their visitation. Shift the encounter, right? So in that, the test results and what the physicians were looking at now allowed them to create individualized care plans for their patients. No two patients are created equal. Right? And so when we looked at what was the physician and the patient experience, right? What would happen if patients had upfront testing and engagement? We had to look at quality metrics as well and look at workflow. And what we found, and this was just presented day before yesterday, hence me being allowed to present it today, was that we found improved patient satisfaction scores. They were happy with the information that their physicians were giving them. When you look at the opposite, patients are largely, they're not confused, but not as adequately informed when they leave their healthcare visitation with their doctor. They don't remember what we just told them, right? We found that providers, it enhanced their workflows. They knew more frequently what the next step was that they needed to do. It shortened the time to the initial diagnosis for people with heart disease. In contrast to the 6 months that I heard, now instead of waiting 6 months, if you had preliminary information up front, you can start acting on it, right? We found rapid patient throughput. Seeing 400 patients in 10 hours is somewhat of a record for us. But we found that there was a reduction in unnecessary testing after 6 months. Many people go on to get their tests done with a blanket approach. Right? What do you need to have done? Get this done, and I'll talk to you about the tests later. But if your tests are normal, then we don't need to send you for those unnecessary tests, such as ultrasounds, such as ECGs. Right? And finally, we found an earlier referral to specialty care, which is also very important. It could take 6 months to 10 months to see a specialist, but we found that was shortened as well. And finally, a shorter time to follow up for higher risk patients. We want to know who the higher risk patients are, mobilize our resources, mobilize healthcare, change their engagement, right? Because these are the people that we need to care for more immediately. And on the other hand, we know who the healthier people are. How do you promote health and wellness? So in looking at the patient experiences, many patients would hopefully agree that I would like the healthcare system to engage me at the capacity in which I need, right? And no more, and hopefully no less, right? So as we look at health and wellness, and we look at chronic disease in our elderly, can we use different approaches that change the patient experience and allow us to act on information that is more available, that is hopefully more accurate, right? And changes what we can do for each other. So coming back to our calculus, right? That we have key requirements for scaling innovation. Many in the room will see that these are just five of many. We must collaborate, right? That is first, collaborate with our patients and our caregivers, right? Collaborate within our institutions across health IT, administration, clinicians, researchers, but also externally. We can't do this alone. Right? So we look to our startup ecosystems in our neighborhoods. We look to our enterprise IT and electronic medical records. Right? We must collaborate along a singular vision to improve the patient experience. What's our risk tolerance to do so? Every institution and every clinic will, of course, be variable in this. But we are like to promote and challenge that we are at a date of change. And if we don't act now, right, the CVSs, the Amazons, et cetera, the Minute Clinics, which will see over 200 million visitations in 2020, right? That's a significant amount from 20 million visitations 3 years ago, right? So we need to change how we're looking at risk, right? Alignment of incentives. Maybe the incentives need to change as well. What was historically the incentive on reducing heart failure readmissions can shift. The incentive is now on improving patient quality of life. Right? What's our long-term vision? Right? What we do now and dedicate resources towards, right, must be within the vision of the institution or the clinic. Right? And finally, there has to be a clear value proposition. Right? And what that value proposition is also very individual. But if we keep the patient, in the center, and our patient experiences in the center, our radar will probably point in the right direction. So, there's a lot that we've learned about patient experiences, and I'm lucky to be a healthcare provider that hopefully is trying to do something different. But many are, right? But with partnership with our patients, it's very interesting what we learn from them, right? We learn that they are more than capable. We learn that they are interested, right? We learn that they want to be engaged differently. And this is not just for your millennials, right? These are for your chronic disease, patients. Many have said, oh, your millennials will automatically adopt this. They'd like to do it. I'll give you an example of a 22-year-old with everything's fine with her, but she's worried that something's wrong. Comes to my office and says, Dr. Bhavnani, just tell me I'm okay. Everything, this tech and all this stuff you're telling me, I'm doing it, but you need to tell me I'm okay, right? So as much as we think that it applies to everybody equally, it does not, right? Understand the pulse of your patient, right? And our users, right? And by doing so, we'll be able to change how we're delivering healthcare. So, this is so true. I've not failed. I've just found 10,000 ways that don't work, right? Is great. And we are very good at it not working in healthcare, right? So with that, I thank you guys very much. I wanted to make time for questions, but it's really been wonderful to address you here. Thank you.